when we call a fracture to be going into non-union? Whenever a fracture is not showing any clinical or radiological sign of progression of union in a prescribed time point. See, in this definition, what are the keywords? The keywords are not showing, means there is lack. Okay, there is lack of something. Radiographic, clinical and radiographic signs. Okay. What are the clinical and radiographic signs of a non-union? The major clinical signs that are seen in a non-union are pain at the fracture site, movement at the fracture site, and inability to bear weight or lack of function. Okay. And what are the radiographic signs or radiological signs? Radiological signs are, you will get bridging callus at the fracture site. So in case of non-union, there is no bridging callus at the fracture site. Okay. Next key point is prescribed time frame. So how can you describe a prescribed time frame? What is the prescribed time frame? As per FDA, it is defined as at least 6 months has elapsed since your fracture and there is no progression of union in the last 3 months. Mane, you have done something, you have done some amount of intervention and 6 মাস চলে গেছে, লাস্ট 3 মান্থসে কোন রকম ইউনিয়নের সাইন তোরা দেখতে পাচ্ছিস না। ওকে, now the next point is delayed union. So what is delayed union? Whenever a fracture is not uniting properly, similarly in the prescribed time point, but it has the potential to unite without any intervention. You don't need to intervene. It will unite on its own. There are chances of union without any intervention. In these cases, clinical and radiological signs of union are present, though they are less than normal, but they are still present. Okay. Next definition is pseudoarthrosis. That pseudoarthrosis is a combined term. Duto part ache. One is pseudo, one is arthrosis. Pseudo means false. Arthrosis means joint. In your skeletal system, movement occurs only at the joints. It cannot occur within a bone. But as per the definition of fracture, there is abnormal movement at the fracture site. So, if a fracture goes into non-union for a long period of time, in due course of time, there is fibrocartilaginous tissue deposition and formation of a pseudo-synovial membrane. So, this will act as a joint. What joint? False joint. Clinically speaking, pseudoarthrosis. Okay. Now, let's discuss in brief about the stages of fracture healing. The first stage is inflammation. Whenever there is a trauma, whenever there is a fracture, the initial stage is hematoma formation. Blood will pool at the fracture site. Now, this blood is very much important for union as it will give a continuous supply of inflammatory cells. And in the next stage, those first two stages are kind of a combined. In the next stage, there is inflammation and cellular proliferation. Along with your inflammatory blood, there will be coming of vast amount of inflammatory cells. And along with inflammatory cells, there will be also influx of osteoprogenitor cells. What are osteoprogenitor cells? These are precursor cells from which osteoblast, osteocyte, osteoclast all are produced. Okay. Now the next stage is callus formation. Just remember the term callus. Callus is the precursor of bone. Okay. After your inflammatory stage, after the inflammatory stage, your inflammatory cells have produced multiple mediators. It will produce multiple mediators like interleukin 1, 6, interferon alpha, and these will provide a fibrous mesh. Now on this fibrous mesh, in due course of time, calcium phosphate will get deposited and it will be converted into a bone. So callus formation, this stage is divided into two parts. First is soft callus and next is hard callus. Soft callus is the stage where calcium and phosphate deposition has not occurred yet, but the scaffold means the layer, the skeleton on which those minerals will get deposited are present. It is invisible in X-ray. Okay, so it's called soft callus. And due course of time, calcium and phosphates will get deposited in this fibrous mesh and will produce bone and will be converted into bone. So the next stage will be hard callus formation. Now hard callus is visible in X-ray. Okay. In the next stage is consolidation. After callus formation, it will get more and more amount of calcium and phosphates will get deposited and it will consolidate, means it will harden up. And in the final stage, it is called remodeling. Now remodeling is a long-term process. It's a very long-term process. It takes a few years. Remodeling, just see the literal meaning. Remodeling means reshaping. A fracture, when it unites, it will not unite in a smooth manner. There will be some amount of bumps, some amount of creases, some crevices will be there. In due course of time, it will reshape into the bone that was present in the pre-injury status. In those bumps, there will be some amount of resorption. In the crevices, there will be some amount of deposition, and it will take the shape of the pre-injury status bone. Okay. Now, there are two types of bone healing. Just compare it with something on your skin cut. If you have a cut on your skin and if you suture it, how will it heal? How will it heal? How will it heal? What is the process? What is called? Scarring. Scarring. No. If you suture the wound end to end, will there be scar? It will heal by primary intention. It's in your pathology. I'm not saying anything new. It will heal by primary intention. It's called primary intention. So for healing in primary intention, you need to have the skin ends approximated properly. Similarly, in primary bone healing, there is no gap at the fracture site and there should be absolute stability. Absolute stability means there is no motion whatsoever at the fracture site. Now second is secondary skin healing. If there is a lacerated wound, some amount of skin loss is there, will it not heal? Will it not heal? If there is a lacerated wound, you cannot stitch that wound, will it not heal? Of course it will heal. It will heal by secondary intention. There will be collagen formation and then skin will be deposited. Similarly, in this case, there is some amount of gap at the fracture site. Very less, but still some amount of gap is present. And micro motions are allowed. Micro motions are allowed. This is called, in the previous thing, there was absolute stability. But in secondary bone healing, it's called relative stability. Relative stability means there are micro motions at the fracture site, but it will never go out of alignment. Okay. Now coming to the causes of the non-union. What are the causes of non-union? First are host factors. What are the host factors? Host factors are diabetes, smoking, prolonged use of NSAIDs or steroids, any rheumatic disease, malnutrition or malignancy. These are patient related. Now what are the fracture related? First, see, the first point is soft tissue interposition. In order for union to occur, the bone should be approximated. May it be absolute stability or relative stability, but the bone should be approximated. Whenever there is a soft tissue interposition at the fracture site, it will act as a barrier. It will act as a barrier. It will not allow bridging callus to form. Okay. The next point is distraction at the fracture site. Distraction in the fracture site means the two fracture fragments are getting pulled away from each other. It's distraction. It's called distraction. Distraction means pulling. So if there is distraction at the fracture site, the fragments are getting pulled away from each other, then bridging callus cannot happen there because there is increasing gap due to distraction. Okay. Next is bone loss. I've told you that the bones should be approximated. If about say 2 centimeter or 3 centimeter, at least 1 centimeter of bone is lost, if a part of bone is missing, then the fracture cannot be approximated with each other. No approximation means no union. Next is damage to the blood supply. In the first two stages of bone healing, it's hematoma formation and inflammation. So, without blood vessels, from where will you get the inflammatory cells? You will not get inflammatory cells. If you don't get inflammatory cells, the process of bone healing will not start. Next is pathological fracture. Pathological fracture means the fracture site is already diseased. The biology is already gone. If the biology is gone, your stages of bone healing will not occur and thus not union. Okay. And the final is, this is the most important point. I will tell this multiple times in this PPT. Infection. Just remember one thing, you cannot have infection and union. You need to treat infection in order to get union. Okay. Now, what are the treatment related causes? But these are called iatrogenic causes. Iatrogenic means surgeon related. First is inadequate reduction. See, if there is inadequate reduction, there is compression at some point of the fracture, there is distraction at some point, there is overlap, there is gap. Too much gap means no bridging callus, no union. Inadequate immobilization. You have reduced it properly, but not immobilized it. In due course of time, it will move and again get displaced. Displaced means again same thing. There will be gap, there will be no union. And finally, distraction at the treatment. Okay. Now coming to the local risk factors. See, what are the local the main gist of this page is periosteum, periosteum and periosteum. Periosteum is the most important thing for bone union. It gives maximum supply of osteoprogenitor cells and it is the main source of blood supply to bone. So, open fractures, in open fracture means stripping of the periosteum. The periosteum is gone. Periosteum is gone. So, again, there will be non-union. High energy fractures and bone devitalization. High energy fractures with bone devitalization means loss of blood supply to the bone. Loss of blood supply to the bone, first two stages of union will not occur and there will be non-union. Severe associated soft tissue injury. Similarly, the periosteum is damaged. If there is bone loss and infection. I've explained it in previous slides also. Now see the two pictures. In the first case, you can see white bone. White bone means there is no periosteum. Periosteum is not white. If you can see white bone, the periosteum is gone. Periosteum gone means union is also gone. And in this case, a plate is applied, but you can see the periosteum has been stripped circumferentially. Okay, so this will hamper your union. Next is instability. See, in both these pictures, both of these are orthopedic implants. Okay? This is called TENS. titanium elastic nail system and this intramedullary nail. Both of these are in active practice of orthopedics. This is also used, this is also used. But TENS is mainly used in pediatric age group. In pediatric age group, we use TENS because the periosteum is very thick. It will not allow macro motions at the fracture site. So, by using TENS, we will just give alignment to the bone. Once you give alignment to the bone, it will unite. But in this case, it has been applied in an adult patient. In adult patient, the periosteum is not that much powerful. There will be macro motions at the fracture site. So, macro motions will prevent bridging callus. See, you can see here, some amount of callus has already formed, but it's not bridging. This is the bridging point. It has not covered the fracture. So, it's converted into a rigid intramedullary nail. Once you have converted it into a rigid intramedullary nail, then the macro motions are stopped. It will allow some amount of micro motions, but the macro motion is stopped. So it will facilitate your union. Okay. And in these cases, see, in these cases, continuous macro motions, callus formation is there, but there is some amount of bone resorption. Okay, some amount of bone resorption will be always present if there is prolonged non-union. And finally, infection, osteomyelitis, soft tissue injury, infected plate, implant, any sort of implant will prevent your union. Then what are the iatrogenic factors? I have told surgeon related factors. So, poor reduction, unstable fixation, and bone devitalization. All three factors will hamper your union. Now, some patient related factors that surgeons face. One is poor bone quality. Once the bone quality is poor, you cannot do anything about it. You need to improve the bone quality and then fix it. Then it will be good for the patient. There will be early union. And if the patient doesn't follow rehab protocol and starts early weight bearing, there will be pressure induced deformity formation. See, in this, a plate has been applied. Okay, a plate has been applied, but the patient has started weight bearing. So what will happen? The pressure completely goes over the plate. The load is completely gone over the plate, and it is not that much strong to bear the weight. So it has bent. Now coming to the clinical presentation. What is the clinical presentation of non-union? First is persistent pain. Your limb will have persistent pain. There will be tenderness at the fracture site. There will be inability to bear weight. There will be pain on stretching the fracture. If you try to move the fracture, there will be some amount of motion and it will be very painful. Okay. There will be continued signs of inflammation. What are the signs of inflammation? Calor, functionality, and and tumor. Right. So calor means heat. Rubor means redness. Dolor means tumor means in our functionality means loss of functionality. Similarly, in union also, you will get all the signs of union, all the signs of inflammation on the overlying area. Now coming to the classification. The classification of non-union is called Weber and Check classification. It is based on site, callus, and infection. Depending on the site, non-union may be diaphyseal or metaphyseal. Metaphyseal is again subdivided into extraarticular and intraarticular. Extraarticular means কালকেই তো বললাম রে, কয়েকজন এসেছিলি তো? Extraarticular means not involving the joint. Intra-articular means involving the joint. Okay. Depending upon the callus, in non-union may be hypertrophic or avascular or atrophic, and depending on infection it may be septic or aseptic non-union. Now what is atrophic non-union? Atrophic non-union means there is minimal, this is the important, this is minimal, there is minimal or no attempt of callus formation following a fracture. Means there is no signs of any callus formation. The biology is gone. The biology is gone. There is no attempt of union at the fracture site. And in case of hypertrophic non-union, there is callus formation. There is abundant callus formation, but it's not bridging your fracture. It's abnormal callus. It is not bridging, and it will not cause union. Okay. Now, what are the radiological signs? What are the radiological evaluation? How can you do? First is X-ray. In case of delayed union, in both the cases, in case of delayed and non-union, in both the cases, the fracture line will be visible. But in case of a delayed union, there will be some amount of callus. There will be some amount of callus, but it is not still bridging. But in case of non-union, there is no to very little callus. This is the main difference. There will be fractures, the fracture will be visible in both the cases. In order to confirm the diagnosis, we can do a CT scan. CT scan, see, this is the X-ray picture. This is the X-ray picture. In this, you can see the fracture line. No bridging callus is seen. No bridging callus is seen. In CT, we will get a magnified view. This will help us in planning the management, and it will also give an idea of the pathoanatomy of the non-union. Okay. Now coming in details of hypertrophic non-union. I have said already that there is callus formation, but it's not bridging. If there is callus formation, means the steps of fracture healing are occurring. If the steps of fracture healing are occurring, then the biology is good. The biology is good. The bone is viable. It has proper blood supply. Then what is the issue? The issue is stability. Stability is lacking. If there is no stability, too much macro motion at the fracture site, it will cause non-union. It will prevent bridging callus formation. So, there are two types. It's also subdivided into two types. One is elephant foot and horse hoof. It depends upon the amount of callus formation. See, in this case, the callus formation is too much. It looks like elephant foot. And this one, there is callus formation, but relatively less than the previous case. It looks like a horse hoof, just named. So, how can you treat it? The only issue is lack of stability. So, if it's lack of stability, give stability. Correct the deformity and give stability. It will heal on its own. In these cases, as the biology is not damaged, as the biology is good, normal, so no stimulation is required. So, no bone graft is required. No biologic stimulation is required. But in case of atrophic non-union, see, the biology is poor. There is no callus formation. No callus formation means the biology is poor. Either the biology is poor or the bone is avascular or non-viable. In some cases, a portion of the bone gets necrotic in these. Then it is called a necrotic non-union. And whenever there is lack of callus formation, there will be lack of stability. Okay. So how can you treat it? First, you need to give stability similar to that of hypertrophic non-union. You correct the deformity, you give stability, but in addition, you need to do two things. First is, if there is necrotic bone fragment, you need to remove it. Until and unless you remove the dead bone fragment, it will not unite. And finally, as the biology is gone, you need to give some amount of biologic stimulation. And by biologic stimulation, it's bone graft. Okay. Now coming to the treatment portion. First are the non-operative management. What are the non-operative management? Indirect intervention. Indirect intervention means it's aimed mainly in correcting the host factors. Second is weight bearing and external fixation. The next few points, these are all historic points. These are not used nowadays. This electrical stimulation, ultrasound stimulation, extracorporeal shockwave theory, parathormone and gene therapy. Just know the names and the basis. I will tell you the basis of these treatments. These are not used nowadays. These are historical facts. First is indirect intervention. So how can you improve the host factors? Cessation of smoking, control of diabetes or metabolic disorder, proper nutrition, decrease the use of NSAIDs or chemotherapeutic or immunosuppressive or steroids. Then weight bearing and external stabilization. See, in few cases we can achieve union by allowing weight bearing. When there will be weight bearing, there will be compression at the fracture site. Compression will stimulate bone formation. But if your stability is not good and you start weight bearing, it will cause deformity. So in these cases, we give an extra layer of protection. We give an external fixator along with the internal fixator. Then we start weight bearing. After union has occurred, the external fixator is removed and the internal fixator is retained. Now, these are all historical facts. Just know the name and the mechanism of action. First is electrical stimulation. What is done? Direct current is applied at the fracture site. And the mechanism is, it alters the electrical potential at the fracture site. It alters the electrical potential at the fracture site and it will recruit more and more osteoids. And it will decrease bone resorption by reducing the osteoclasts. Okay. Ultrasound stimulation. Low intensity pulsed ultrasound waves are applied at the fracture site. It is said to increase osteoblastic activity and osteogenesis. Extracorporeal shockwave therapy. It is a higher version of that electrical stimulation that you have, but it's given under regional anesthesia. Now the two terminologies in this page, these are still used nowadays. First is parathyroid hormone. Parathormone is regulator of your calcium metabolism. It activates both osteoblast and osteoclast. Dutoke activate koche ra. It will activate osteoclast and cause bone resorption and will increase the calcium level in your blood. On the other hand, it will also activate osteoblasts which will use that calcium for your fracture union. তাহলে যদি দুটোকেই স্টিমুলেট করছে তাহলে আমার নেট রেজাল্টটা কি হবে? দ্য নেট রেজাল্ট উইল ডিপেন্ড অন দ্য পিরিয়ড অফ তুই কতদিন ধরে ইউজ করছিস। It is seen that if you use parathormone for a maximum period of 3 months, it will activate osteoblasts more than osteoclasts. So the net result will be bone formation. And the final point is gene therapy. Gene therapy means we aspirate bone marrow from the iliac crest and inject it directly into the fracture site. In some cases, it has shown to facilitate union faster. Now, surgical management. So what are the principles? These are the principles of surgical management. First and foremost is cure infection. You cannot do any sort of surgery when there is infection. Whatever you will do, it will get infected. So you need to first cure infection. If there is too much deformity, correct it, provide proper stability, and give biologic stimulation. Biologic stimulation means bone graft whenever it's required. It's required in what type of non-union? Bone graft is required in what type of non-union? Hypertrophic or atrophic? Bone graft is used in what type of non-union? Hypertrophic or atrophic? atrophic. So what is the timing of operative intervention? Go to the first slide. What was the prescribed time point? What was the prescribed time frame for a union? When can you কখন তুই বলতে পারবি যে নন ইউনিয়নে চলে গেছে? 6 months. So if it is 6 months, then until and unless 6 months has elapsed, you cannot stamp it as a non-union. If you cannot stamp it as a non-union, there is no question of a surgical intervention. So any sort of surgical planning or intervention is done only after a minimum time of 6 months. And again the same point, you need to treat infection before operating. You need to treat it. Now how can we add stability? তিন ভাবে করা যেতে পারে. You can apply plate and screw, intramedullary devices and external fixator. Now the choice of implant depends upon the type of non-union, the soft tissue condition, size and position of the bone fragment, and if there is any bone defect. First is plate and screw fixation. Plate and screw fixation কোন জায়গাগুলোতে লাগে? When we are aiming at absolute stability. With plate and screws, you can achieve absolute stability. Means you want primary bone healing. You don't want secondary bone healing. You want primary bone healing. In which cases it is used? When there is absent medullary canal. Medullary canal ই নাই তুই কোত্থেকে nail ঢোকাবি? ঢোকাতে পারবি না. So whenever there is absent medullary canal, then you use plate and screws. Metaphyseal non-unions. Metaphyseal non-unions. Metaphysis is the active portion of the bone. It is the active portion of the bone. So you don't need relative stability there. If you give, it's bound to have hypertrophic non-union. Any sort of non-union in the metaphyseal area will be hypertrophic. So in the hypertrophic, what was lacking? What was absent? Biology was absent. Biology was good. Biology was good. Stability was lacking. Stability was absent. So if you just give stability, it will unite. And when there is an open fracture or removal of prior implants, your fracture site is already opened. Either it's opened by trauma or you are opening it. Once you have opened it, there is no logic in keeping a intramedullary nail, in giving a intramedullary nail. Just open the fracture, remove the implant or debride it and give a plate, because the field is already made ready by the trauma or previous implant. Now intramedullary nail. Intramedullary nail means inside the medulla, inside the medullary cavity. So intramedullary nail can be used to treat non-union by three forms: pre-existing nail, exchange nailing or dynamization. Pre-existing nail means you have treated, it's mainly used in case of long bones. যে বোনগুলোর মেডুলারি ক্যাভিটি আছে সেখানেই তুই নেল ঢোকাতে পারবি. মেডুলারি ক্যাভিটি অ্যাপার্ট ফ্রম লং বোনস কোথায় আছে? কোথাও নেই. So it is mainly used in long bones, femur, tibia, radius, ulna, humerus, এগুলো. So as per the first point, you have treated a fracture conservatively and it has failed. So you can convert it into intramedullary nail by surgical intervention. In the second part, in some cases, when the nail diameter is much less than the canal diameter, canalta onek chauda, nailta onek patla, so there will be movement of the nail will start toggling inside the cavity, medullary cavity, and it will not give proper stability. There will be macro motions and non-union. So what we do, we exchange it with a greater diameter nail. Okay. And finally dynamization. এই কনসেপ্টটা ভালো করে বোঝ. Dynamization. ছবিটা দেখ. This is done intramedullary nail. Which bone is this? Which bone is this? Tibia. টিবিয়াতে আমার একটা নেল দেওয়া আছে, নিচে দুটো স্ক্রু দেওয়া আছে। ডাইনামাইজেশন কি বলে, আমি এই দুটো স্ক্রু বার করে দিলাম, এই দুটো আমি বার করে দিলাম। ডাইনামাইজেশন লিটারাল মিনিং হচ্ছে মুভমেন্ট, আমি মুভমেন্ট দিচ্ছি। তো যখনই পেশেন্টটা হাঁটবে, প্রেশার দেবে, তখনই একটা আপওয়ার্ড ডিরেক্টেড প্রেশার হবে। যখনই আপওয়ার্ড ডিরেক্টেড প্রেশার হবে, তখনই এই পোর্শন বোনটা আরো ওপর দিকে ঠেলবে, কিন্তু নেলটা উঠবে না আমার, কিন্তু এইখানে প্রক্সিমালি দুটো স্ক্রু দেওয়া আছে, নেলটা উঠে যাচ্ছে না, নেল হাড় থেকে বেরিয়ে যাবে তা হবে না, কিন্তু আমার ফ্র্যাকচার সাইডে কম্প্রেশন হবে। নেলটা কি করছে, ইট ইজ জাস্ট গিভিং ডিরেকশন টু দ্য ফ্র্যাকচার, কোন দিকে সে মুভ করবে। এই দিকে মুভ করতে পারবে না, এই দিকে মুভ করতে পারবে না, এ শুধু ওপর নিচেই মুভ করতে পারবে। তো ওপর নিচে মুভ করছে মানে there will be compression at the fracture site which will facilitate union. ওকে, বুঝতে পেরেছিস ডায়নামাইজেশন, বুঝতে পেরেছিস কাকে বলে? ইফ ইউ ডোন্ট আন্ডারস্ট্যান্ড টেল মি। বুঝতে পেরেছিস? বলবার একবার। দেখ এইখানে এটা নেল, তো নেলের নিচে দুটো স্ক্রু আর ওপরেও দুটো স্ক্রু থাকবে। ডায়নামাইজেশন আমি কি করলাম, এই দুটো স্ক্রু আমি ফেলে দিলাম, খুলে দিলাম, তাহলে কি হলো, নিচে কোনো ফিক্সেশন নাই। যখন আমি এটাতে পায়ে ভর দেবো, তখন একটা আপওয়ার্ড ডিরেক্টেড ফোর্স হবে, ওপর দিকে উঠবে, কিন্তু নেলটা উপরে উঠবে না, নেলে দুটো স্ক্রু দেওয়া আছে অলরেডি। এবার কি হবে, দেয়ার উইল বি কম্প্রেশন এট দ্য ফ্র্যাকচার, এই মুভমেন্ট হবে, এই অ্যাক্সিসে কন্টিনিউয়াস মুভমেন্ট হবে, মানে তো স্যাজিটাল প্লেনে মুভমেন্টটা হবে, মুভমেন্ট কোরোনাল প্লেনে হবে না। নেলের জন্য জাস্ট ডিরেকশন পাচ্ছে ফ্র্যাকচারটা কোন দিকে মুভ করবে, স্যাজিটাল প্লেনে মুভ করছে, কোরোনাল প্লেনে মুভ করে না, মিডিও ল্যাটারাল মুভমেন্ট হবে না, শুধু আপ অ্যান্ড ডাউন মুভমেন্ট হবে। যত আপ অ্যান্ড ডাউন মুভমেন্ট হবে তত বেশি কনসলিডেশন হবে, তত বেশি কম্প্রেশন হবে আর বোন ফর্মেশন হবে। নেক্সট ইজ এক্সটার্নাল ফিক্সেশন। দেখ প্রথমে বলেছিলাম আমি ইনফেকশন, ইনফেকশন কিওর না করে নন ইউনিয়ন ট্রিট করা যায় না। তাহলে ধরে নে একটা ইনফেকশন হয়েছে, ইনফেকশন কিওর করতে অ্যাটলিস্ট 3 months তো সময় লাগবে। ইউ ক্যানট কিপ দ্য পেশেন্ট without any intervention for 3 months, it's very painful. So what can be done, we can give external fixation. See, external fixation means আমার হাড়ের ভেতরে শুধুমাত্র এই পিনগুলোই আছে, বাকি যা রড ক্ল্যাম্প যা কিছু দেখতে পাচ্ছি সব কিছু কিন্তু আমার স্কিনের বাইরে। তো মিনিমাম ইমপ্লান্টেশন ইন দ্য বোন, সেটাই মেন অ্যাডভান্টেজ হচ্ছে এক্সটার্নাল ফিক্সেটর। ইন সাম কেসেস এক্সটার্নাল ফিক্সেটর ইজ ইউজড অ্যাজ আ ডেফিনেটিভ ম্যানেজমেন্ট, এটাতেই আমরা ইউনিয়ন অ্যাচিভ করি। এক্সটার্নাল ফিক্সেটর আর টু টাইপস। ফার্স্ট ইজ লিনিয়ার এক্সটার্নাল ফিক্সেটর, দিস ইজ লিনিয়ার এক্সটার্নাল ফিক্সেটর। লিনিয়ার মিন্স একটা প্লেন কিংবা দুটো প্লেন, means kind of 2D external fixator. This is 2D external fixator. Okay, and the next is circumferential. This you can say this is a 3D external fixator. This is called Ilizarov fixator. এই দুটোর কেসের ক্ষেত্রে আমরা কি করব, যে মিনিমাম ইমপ্লান্টেশন অ্যাট দ্য বোন করে we can achieve stability. And once we have achieved stability, the patient will be comfortable and we can easily treat the infection. If required, we can convert this into an internal fixator, plate, rod, screw কিছু করলাম, কিংবা এটাই আমার ফাইনালি হলো, এটাতেই আমার ইউনিয়ন হয়ে গেল। এবার হচ্ছে গিয়ে বায়োলজিক স্টিমুলেশন। বায়োলজিক স্টিমুলেশন মানে বোন গ্রাফট। এবার বোন গ্রাফট ক রকমের হয় এটা লেখা নাই, বলে দিচ্ছি লেখ। ফার্স্ট হচ্ছে cortical bone graft. Second is cancellous bone graft. Cortical bone graft মানে কর্টেক্সটা আছে তোর, it is mainly used to provide stability. The cortex is the hard portion of your bone and cancellous bone is the active but soft portion of the bone. So cortical bone is mainly used to provide stability and cancellous bone is mainly used to provide biologic stimulus. So what are the properties of autograft? এটা হচ্ছে ডিপেন্ডিং আপন দ্য মেটেরিয়াল, ডিপেন্ডিং আপন সোর্স কি কি হতে পারে, অটোগ্রাফট, অ্যালোগ্রাফট, জিনোগ্রাফট। Autograft means we are taking bone from the same person. Allograft means we are taking bone from a different person, preserving it and using it at our convenience. And xenograft. Xenograft means we are taking bone from a different species, not human, from a different species and using it. So what are the properties of autograft? First is it is osteogenic. Osteogenic means along with the bone graft, we are providing ready-made osteoprogenitor cells to the fracture site. Second is osteoinductive. Osteoinductive means the bone graft is stimulating local mesenchymal cells. Local mesenchymal cells. প্রথমটাতে আমি রেডিমেড সেলস দিচ্ছিলাম, সেকেন্ডটাতে লোকালি আমার সেলস বাড়ছে, and third is osteoconductive. Osteoconductive মানে it will give the skeleton on which bone will deposit. It gives a scaffold. It's called scaffold. Scaffold মানে হচ্ছে শীটের মতন থাকে, মাল্টিপল শীটস এর মতন থাকে যার উপরে লেয়ারিং অফ ক্যালসিয়াম অ্যান্ড ফসফেট হয়। ওকে, now what are the types of biologic stimulus apart from bone graft? First is aspirated stem cell, এটা আমি বলেছি জিন থেরাপি। Next is demineralized bone matrix. Demineralized bone matrix is kind of a chemical. এটা কি হচ্ছে যে আমরা ক্যালসিয়াম আর ফসফেটটাকে ছেড়ে দিয়ে ওটাকে আমরা রিমুভ করে দিয়ে শুধুমাত্র স্ক্যাফোল্ডটাকে প্রিজার্ভ করলাম, দিয়ে তারপর সেটাকে অ্যাপ্লাই করছি। প্লেটলেট রিচ প্লাজমা, গ্রোথ ফ্যাক্টর, অটোজেনাস ক্যান্সারাস বোন গ্রাফট অলরেডি বলে দিয়েছি। প্লেটলেট রিচ প্লাজমা অ্যান্ড গ্রোথ ফ্যাক্টরস, দিজ আর নট ইউজড, জাস্ট নো দ্য নেমস। নাও কামিং টু দ্য সামারি, ফাইনালি প্রিন্সিপাল কি কি আছে ফর ট্রিটমেন্ট অফ নন ইউনিয়ন? Stabilization, enhancement of biology. You need to make your fracture stable. Give biological stimulation if it is a atrophic non-union. And finally, eradication of infection. Again, you need to eradicate infection. And how can you prevent or delay non-union? Proper biologic fixation. That proper biologic fixation means there are a few rules in orthopedic so that a fracture doesn't go into non-union. First is all those things: proper stability, proper reduction, deformity correction. 3. And the next is minimal soft tissue stripping. Minimal soft tissue stripping. 4টে rule আছে, এই 4টে rule follow করলে the chances of non-union are very less. And next is early recognition of delayed union so that you can do intervention in proper time. Now next topic হচ্ছে malunion. এটা বড় টপিক নয়, বেশিক্ষণ লাগবে না। Malunion means the fracture has united, but it has united in an abnormal position, in a non-anatomical position. Non-anatomical position. Okay. প্রথমেই বললাম ফ্র্যাকচার ইউনাইট করলে কখনো সেটা নর্মাল বোনের মতন দেখতে লাগে না, কিছুটা বাম্পস, ক্রিজেস এন্ড অল এইসবগুলো থাকে। So some amount of minor malunion is present in all fractures, but whenever there is overt malunion, means overt deformity, it will affect the functionality of the patient. What are the sites? Upper, lower extremity, spine and pelvis and these things. Okay, depending upon the location, intra-articular and extra-articular, and within extra-articular, metaphyseal and diaphyseal. Now what are the types? First is simple. Simple মানে just skeletal malalignment হয়েছে, just malalignment হয়েছে, just আমার একটা অ্যাঙ্গুলেশন হয়েছে এইরকম টাইপের। কিন্তু in case of complex, malalignment is so much that it's affecting the surrounding soft tissues, আর যখনই সারাউন্ডিং সফট টিস্যুস আমার এফেক্ট হচ্ছে তখন আমার জয়েন্টস গুলো, সারাউন্ডিং জয়েন্টস গুলো, প্রক্সিমাল অ্যান্ড ডিস্টাল জয়েন্টস গুলো এফেক্টেড হবে। অ্যান্ড ডিরেকশন, ডিরেকশন হচ্ছে কি, প্রথমে কি অ্যাঙ্গুলার, মিনস ফ্র্যাকচারটা একটা অ্যাঙ্গেলে জুড়েছে, এটা হওয়ার কথা এরকম ভাবে জুড়লো। সেকেন্ড ইজ রোটেশনাল, মিনস আমার হওয়ার কথা এরকম এরকম, কিন্তু জুড়লো হচ্ছে এইরকম, দিস ইজ দ্য রোটেশনাল ডিফর্মিটি। থার্ড ইজ ট্রান্সলেশন, ট্রান্সলেশন মিনস আমার জুড়লো আইদার এই 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 और এই, ঠিক আছে। অ্যান্ড ফাইনালি লেন্থ। Etiology is nothing but failure of your treatment, nothing else. If you don't give proper stability, if you don't give proper reduction, it will malunite in due course of time. Now, what is the importance? This is an important thing. What is the importance of limb alignment? That আমাদের একটা সেন্টার অফ গ্র্যাভিটি আছে, ডিউ টু দিস সেন্টার অফ গ্র্যাভিটি উই ক্যান কিপ আওয়ার ব্যালেন্স। যখনই আমার কোনো একটা লিম্ব ম্যালিউনাইট হলো, অ্যালাইনমেন্ট আমার গন্ডগোল হয়ে গেল, মানে আমার সেন্টার অফ গ্র্যাভিটিটা সরে গেল। সেন্টার অফ গ্র্যাভিটি যখনই আমি সরলো, যেদিকে সরবে সেদিকের জয়েন্টসগুলোর ওপর বেশি চাপ পড়বে, বেশি চাপ পড়বে, ইনিশিয়ালি আমার সেই জায়গাগুলোতে বেশি পেন হবে, অ্যান্ড ইন লং টার্ম আমার আর্থারাইটিস ডেভেলপ করবে। So, the immediate effect is functional limitations and pain, and long term is arthritis. Common sites of non-union are, তোরা সবাই জানিস, Colles fracture and supracondylar humerus fracture. Colles fracture এর malunited ভেরিয়েন্টটাকে কি বলে? হয়েছে? Colles fracture ক্লাস হয়েছে তো? Colles fracture এর malunion কে বলে dinner fork deformity. What was the direction of movement at the fracture site? Colles fracture definition এ আছে, there will be dorsal angulation or dorsal displacement. ঠিক আছে, এই ছবিটা দেখ, এই ছবিটা দেখ, there is dorsal angulation and it has united. ডিনার ফর্ক মানে হচ্ছে সিম্পল ফর্ক, ইমাজিন কর যেরকম ফর্ক দেখতে হয়, এটা আমার ফর্কের স্টেম, একটা এইরকম এরকম একটা অ্যাঙ্গেল হয়ে আবার এরকম করে সরে যায়। সিমিলারলি এই আমার যাচ্ছে, এই আমার একটা গেল, আবার সামনের দিকে চলে গেল, ইট লুকস লাইক আ ডিনার ফর্ক। অ্যান্ড সেম থিং ইন সুপ্রাকন্ডালার হিউমারাস। সুপ্রাকন্ডালার হিউমারাসটা আমি আর একটু ডিটেলসে বলবো নেক্সট স্লাইডে। ম্যানেজমেন্ট হচ্ছে প্রথমে রেডিওগ্রাফ করবি, রেডিওগ্রাফ মিন্স এক্সরে। এক্সরে কি করবি? এক্সরে করবি বায়োল্যাটারাল লিম্বের, সো দ্যাট ইউ ক্যান কোয়ান্টিফাই দ্য অ্যামাউন্ট অফ নন ইউনিয়ন, ইউ ক্যান কম্পেয়ার ইট উইথ দ্য নর্মাল লিম্ব, অ্যান্ড ইউ ক্যান ডু সিটি স্ক্যান টু সি ইফ দেয়ার ইজ এনি রোটেশনাল। রোটেশন যদি থাকে ইউ ক্যান নট সি ইন রেডিওগ্রাফ। কেন রেডিওগ্রাফে দেখতে পারবি না? কারণ দিস ইজ আ 2D ভিউ, আর রোটেশন ইজ আ 3D ডিফর্মিটি, সেটার জন্য ইউ রিকোয়ার সিটি স্ক্যান। আর যদি লং টার্ম থাকে, সিভিয়ার ম্যালালাইনমেন্ট থাকে, তাহলে বলেছিলাম জয়েন্টস এফেক্টেড হবে। ইন অর্ডার টু সি দ্য জয়েন্ট স্টেটাস ইউ নিড টু ডু MRI, and in some higher institutes arthroscopy can also be done to directly visualize the joint. Now deformity correction, আবার ট্রিটমেন্ট পোর্শন আসছে। ডিফর্মিটি কারেকশন, ডিফর্মিটি আছে আমার, ডিফর্মিটিটা কারেক্ট করতে হবে। In case of upper limb, 3 to 4 centimeter of shortening is well tolerated. 3 to 4 centimeter কেন? কারণ আমরা হাতে ভর দিয়ে চলি না, সেটার জন্য আমাদের যদি একটু বেশি ডিফর্মিটি হয় we can tolerate it. But in case of lower limbs, maximum of 2 centimeter can be treated with a shoe rise. এক্সেসিভ যদি আমার ডিফর্মিটি থাকে তাহলে আমাদের সেন্টার অফ গ্র্যাভিটি আমাদের সরে যাচ্ছে, আমরা দুটো পায়ে ভর দিয়ে নর্মালি সেম প্রেসারে হাঁটতে পারবো না। নাও ম্যালইউনাইটেড হিউমারাস। ম্যালইউনাইটেড হিউমারাসের ক্ষেত্রে যেটা হয় সেটাকে বলে ক্লিনিক্যালি বলে কিউবাইটাস ভাইরাস। কিউবাইটাস ভাইরাস মিন্স elbow is cubitus, elbow is cubitus, varus means deviation towards your midline, এটাকে বলে গানস্টক ডিফর্মিটি। গানস্টক কেন ডিফর্মিটি বলে? see the picture, see the picture, see the architecture of the hand, see the shape of the hand, it looks like the butt of a rifle, সেটার জন্য এটাকে গানস্টক ডিফর্মিটি বলে। নাও ট্রিটমেন্ট পোর্শন। ট্রিটমেন্ট পোর্শন যদি বলি, একটাই জিনিস আছে, ডিফর্মিটি হয়েছে কারেক্ট করো। এবার আমার ক্ষেত্রে কি ডিফর্মিটি হয়েছে? এলবো আর হাতটা আমার ভ্যারাসে চলে গেছে, তাহলে আমাকে ডিফর্মিটি কারেকশন করার জন্য কি করতে হবে? হাতটাকে আমাকে আবার ভ্যালগাসে নিয়ে যেতে হবে। এবার কি করে নিয়ে যাবো? আমার তো পুরোটা সলিড বোন, কোনো মতে নিয়ে যেতে পারবো না আমি। হোয়াট উই ক্যান ডু, উই ক্যান টেক আ wedge, a wedge, we will take a wedge from the distal humerus with a base at the lateral cortex. যখনই আমি একটা wedge নিলাম, this is your wedge, এটা wedge. So lateral wedge osteotomy is the treatment of choice for deformity correction. Just know the name, you don't need to know the details of it. It's called French osteotomy. So finally, what are the goals of treatment? First is improve in functionality, decrease pain and prevent arthritis. And treatment of malunion is correction of deformity. There is some deformity, correct it. And that's all for today.